Good afternoon, and welcome to our third web-based seminar on the TB cohort review process. TB cohort review in action, putting it all together. My name is Bill Bauer, and I'm the Director of Education and Training at the Charles P. Felton National TB Center, a component of the New Jersey Medical School Global TB Institute. I will be moderating today's program. This is the last of a series of 3 best practices webinars that highlight the TB cohort review process. The specific objectives are these. By the end of the seminar, you'll be able to describe the flow of activities in a cohort review. You'll be able to analyze the comments and feedback that come from the program manager and the medical reviewer and other staff who pitch in the discussion. You'll be able to examine critically the sort of clinical and programmatic teaching points that are used to highlight the lessons that are learned in the cohort review. You'll be able to identify issues that need follow-up by different staff members who are present. And you'll be able to identify benefits of the cohort review process and the program improvements that you can expect if you start doing this as part of your program. Our faculty today, they are myself, Kim Fields, Section Manager, the TB Services at Washington State Department of Health, Sue Wang, Medical Director at the Ben Franklin TB Clinic, TB Consultant for the Ohio Department of Health, and Assistant Professor of Infectious Diseases at Ohio State University, Christina Dogby, Epidemiologist, Philadelphia Department of Public Health, Tuberculosis Control Program, Mary Katie Sisk, the Supervisory Nurse Coordinator at the District of Columbia Department of Health, Bureau of Tuberculosis Control. And joining us today, we have also Anthony Lloyd, Disease Intervention Specialist at the Philadelphia Department of Public Health Tuberculosis Control Program. Now, I know that participating today in the webinar, we have a mixed audience. Some of you may be program managers, medical directors, consultants, epidemiologists, public health nurses, supervisors, case managers, outreach workers, or any of a number of other health occupations that are contributing in the effort to eliminate TB. I think that each of you will see a part that you can play in a cohort review portrayed today. Now, I want to take a look at some of the background resources. I want to remind everyone that most of the information in the series of webinars comes from our experience as well as these rich sources here, the instruction guide and the video DVD that are both entitled Understanding the TB Cohort Review Process. The guide itself is undergoing revision, and an updated version will be available soon. I've put up here a constellation of the TB control staff who are going to be involved in our simulated cohort review today. You've met most of them on our last webinar, and I'll go around clockwise from the top. Kim Field from Washington is the program manager. Christina Dogby is the data analyst or epidemiologist. Katie Sisk is a case manager. And likewise, Anthony Lloyd is a case manager. On the left, Dr. Shuhua Wang is the medical reviewer, and this comprises the team of 5 people who are going to be conducting and they'll actually show you how they're doing the cohort review. The last webinar, you learned about the activities that they do and the roles that they play in preparing for it and following it up. But right now, you'll see them or hear them actually doing it. I want you to think of our presenters today sort of as actors playing their roles. They're not to be considered flawless TB experts. If anyone makes any inadvertent mistakes in following TB guidelines or procedures, this is intended to reflect real work situations. People may, in their doing a cohort review today, give evidence of priorities or policies or practices that are different from what your program does. That's okay. I want you to focus on the process and the teamwork that makes a cohort review happen rather than on any particular case detail. In addition, you may notice that the 2 case managers, that would be Anthony and Katie, you may notice that they're using slightly different forms when they make their case presentations. That's because they come from programs in Philadelphia and in Washington, D.C. I want you to take this as an example of how you can customize the forms and the approach to meet your own program's needs. What's really important is that the order of the information presented from the forms be the same as the order in which it is collected on a spreadsheet. Now, I also want to point out that Christina, the epidemiologist, will be working in the background and she's going to be checking on her spreadsheet to make sure that it reflects all of the key data that the case managers present. So that's all the opening words I have now. I'll turn the program over to Kim Field, who as the program manager will be leading the cohort review meeting. Kim?
Thank you, Bill, and welcome to our cohort review today. We will have our group of presenters and reviewers. We have Dr. Sue Wang and Christina, Katie, and Anthony, as you heard introduced by Bill. I'd like to go over a few ground rules before we begin the cohort review, which will assist in a seamless presentation and consideration of the presenters. So if you brought cell phones in to the meeting today, please put them on vibrate. And if you do have to take a call and go outside the room, be respectful if there's other offices or other individuals that you might be interrupting. And when participating via conference call, please do not place your phone on hold so that we might be hearing music or whatever is on that phone when it's on hold. And it is just really important to allow the presenters of the case to go through their case presentation, and then we wait to the end, and then we'll review the cases, and then the contacts are reviewed, and we'll review, and we hold our questions to the end to be respectful of each presenter. So if there's no questions on our ground rules, I'd like to have Christina now present a summary of the demographic and characteristics of our cohort today. Christina?
Thank you, Kim. Good afternoon, everybody, and welcome to the cohort review. I will be going over the medical and demographic characteristics of the cases that were counted during this quarter, which is the second quarter of 2010. So this quarter we counted 25 cases. We counted 12 in the month of April, 8 in the month of May, 5 in the month of June, for a total of 25 cases. Those are cases by age group. As you can see, we had 2 cases under the age of 5. We had 4 in the age 5 to 17 bracket, 2 in the ages of 18 to 24, 6 cases that were aged 25 to 44, 8 cases that were 45 to 65 years of age, and 3 cases that were older than the age of 65. This is our cases by birth country. As you can see, the majority of our cases, 14, were non-U.S. born compared to 11 U.S. born cases. Of the 14 cases born outside of the United States, 6 have been in the United States less than 5 years, and 8 have been in the United States 5 years or longer. The countries represented by our foreign-born patients include the Philippines, Laos, Puerto Rico, Indonesia, Haiti, Cambodia, China, the Dominican Republic, Brazil, Guinea, and Vietnam. This is our cases by special therapy status, which is their HIV status. We had 17 cases that were HIV negative, 4 cases that were confirmed to be HIV positive, and 4 cases in which at this time of cohort, their HIV status is unknown. Here's the presentation of the clinical characteristics for the TB cases counted this quarter. We had 22 culture-positive pulmonary cases, of which 12 were sputum smear positive. We had 2 extrapulmonary only cases, no cases of both pulmonary and extrapulmonary disease, 1 clinically confirmed case, 1 multi-drug resistant case, and 2 cases that showed other drug resistance, which included 1 case resistant to INH and 1 case that was resistant to streptomycin. For this quarter, we had 1 large extended contact investigation in a local nursing home. And now I'm going to turn it over to our case presenters.
Thank you, Christina. I notice in your data there that, as is a national trend, the foreign-born and then living here over 5 years. So often what we're seeing is that the longer someone lives here with latent TB infection, they have other risk factors that they develop disease. So thank you for that summary. Our first presenter today, if there's no other question, is going to be Anthony, and he will start out with case number 1. Anthony?
Yes. Case ID number 102345, 49-year-old U.S. male, homeless male born in the USA, special therapy positive and on ART. This is a pulmonary case, sputum smear positive 4+, culture positive, source of culture sputum. Date treatment initiated was 5/28/2010. Date assigned was 4/20/2010. Date interview was 4/21/2010 in the hospital. Persons currently on rifabutin, INH, pyrazinamide, EMB, that was actually administered in the hospital. Sputum conversion within 60 days, yes. Chest X-ray result is abnormal, non-cavitary. Person completed a total of 6 months on DOT, and completion date was 10/21/2010.
Thank you, Tony. I have a question, again, related to the start date for the directly observed therapy. Could you kind of review from this case why there was a delay in the directly observed therapy?
Well, the patient was discharged on 5/27/2010 and started on DOT on 5/28.
And so there was no DOT in the hospital?
The DOT was actually started in the hospital.
Okay, excellent. Dr. Wang, you had some questions related to this case, I believe.
Thank you, Kim. Tony, once again, going back to the DOT question, he had a compliance rate about 85%. Can you tell me what some of the barriers were in getting a higher compliance rate and how you may have overcome some of these barriers?
Yes, originally arrangements were made to DOT the patient early in the morning by 8 o'clock. At the time, I was also aware that there was a 10 p.m. curfew. At the shelter was clearly stated that no one would be admitted after that time. And at times, patient would miss the curfew, therefore it would make it difficult to track them down the next day. After a conversation I had with the patient regarding missed dosage as well as issue a health department order, he then agreed to go to the DOT center in the morning for his meds if he couldn't make it in the morning. Other than that, there were no major barriers. The patient's major concern was applying for Social Security benefits and other services. But those issues were referred to our program social worker who ultimately was able to spend time helping them overcome some of those issues.
Great, thank you. I also had one additional question with regard to the duration of therapy. Some physicians may want to extend treatment in an HIV-TB co-infected patients to longer than 6 months. Can you tell me how that decision was made?
Yes, I reviewed the chart and treatment regimen along with our medical reviewer who found that the duration of treatment on the patient was sufficient enough.
Great, thank you.
Any other questions? Okay. Tony, you want to go on with the contact investigation for this case?
Yes, there were 15 contacts identified. There were 15 appropriate for evaluation. There were 7 evaluated. There were 5 negative, 2 LTBI with new TST, no disease. There was 2 appropriate for treatment of latent TB infection. There were 2 started on treatment, 1 current to care, and 1 lost to follow-up.
The 1 case lost to follow-up, Tony, were you able to send an interjurisdictional follow-up or locate where this person might have gone?
Yes, I did a number of things. I conducted what they call a jail track system. Surge also did a Department of Welfare check. He actually gave one of his names, and I actually put it on Facebook and see if we can locate the patient through Facebook. And that person didn't friend me. I'm still waiting for an acceptance. I also provided names to the State Shelter Administration just in case they show up at one of the shelters as well.
Dr. Wang, you had some questions on some of the contacts here.
Yes. Tony, you stated that there were 15 contacts identified, but only 7 were evaluated. Can you tell me what the reasons why the others were not evaluated?
Well, I did manage to test all 15 contacts in the first round. Although I stressed the importance of retesting in 3 months, some were very apprehensive about providing additional locating information to me or the shelter. Neither of them left any forwarding addresses.
Okay, thank you.
Tony, I have a question regarding your contacts. Are they offered HIV testing at the time of the investigation?
Yes, they were all offered. I tested them for HIV through rapid testing during the first round of skin testing, and all were negative.
And so this is real important. That's wonderful you've done that because they may have, a false negative result on the skin test if we're not aware of that HIV status. Any other questions for Tony on the contacts? Okay, Tony, I think you have case number 2.
Case number 2, 102347, 32-year-old male born in Mexico. Special therapy is negative. Pulmonary case, sputum smear positive 4+, culture positive. Source of sputum, date initiated was 4/20/2010. Date interview was on the same day, 4/20/2010, which is also the date assigned. Recommended initial therapy? Yes. Sputum conversion within 60 days? No. The person didn't convert within 60 days. Pan-sensitive and cavitary. Currently taking TB medication, has completed 9 months of TB medication on DOT, and is likely to complete treatment within 12 months.
Thank you, Tony. Dr. Wang, you had some questions related to this case.
Yes, so one of my questions is regarding the DOT therapy, which was not done initially. Given patients is high risk for noncompliance, was there any consideration for ordering DOT on this patient?
Yes. During initial assessment, the patient stated that he's a construction day laborer who worked at 6 o'clock who started work at 6 o'clock a.m. And he also asked if he could self-administer the TB medication. But before the decision was made to allow the patient to self-administer, I offered other options such as being DOT at one of our 10 district health centers during work hours. The patient claimed that most of the employers were not willing to allow him to leave the site. So I brought the issue back to the team nurse who decided to conduct a 2-week trial to allow the patient to self-administer. At that time, I gave the patient office number along with my phone number to contact me just in case anything changes. Once I got a chance to speak to the patient in the hospital again, myself along with a Spanish-speaking outreach worker, we educated the patient regarding the seriousness of his illness. The outreach worker also agreed to adjust their schedule to start at 6 o'clock a.m. to DOT the patient. I then followed up with a health department order, and that seemed to do the trick.
Thank you. Seems like you guys overcame a lot of challenges to get him DOT, which is a great job. And I also want to commend the team for extending the treatment since the patient was culture positive at 2 months to extend it beyond the 6 months to 9 month treatment. And then will you be getting a final chest x-ray, or did you get one before the closing date?
Not yet. Since he's due to complete next month, at that time we'll obtain a final chest x-ray.
Great, thank you.
Tony, that was excellent. This is a very challenging case, as a lot of our cases are. So I'm anxious to hear how the contact investigation went.
Yes. There were 16 contacts identified. There were 16 appropriate for evaluation. There were 12 evaluated. 4 refused. There were 8 negative. There were 4 LTBI, new TST, no disease. There were 4 appropriate for treatment for a latent TB infection. 4 started on treatment for LTBI, and 4 current to care.
Dr. Wang, you had a question?
Yes, with regards to the contact, were there any children that were under the age of 5 that were identified, and if so, was window prophylaxis offered to these children?
Yes, there were 2 kids, 5 and 7, that were actually current to care. They started on LTBI treatment, and they're right now current to care. During that time, we actually conducted another re-interview. There were no other contacts identified outside of the house as well that could benefit from a skin test or anybody who was HIV positive.
Great, thanks.
So you were able to do the directly observed therapy with those children then at the same time of the case, right, Tony?
Yes.
With those that had refused, what type of education or work did you do with those individuals to stress the importance of being exposed to TB?
There were numerous attempts to stress the importance of follow-up testing. I did get a chance to do the first round of testing, and they were negative. The contacts, they just remained adamant about not getting tested. They never actually gave a good reason, but for their convenience, what I did do is I gave them a list of some of the local district health centers just in case they wanted to follow up on their own.
Besides the family, you really certainly identified that you worked very well with this family. Were there any other social activities outside of the work sites that you identified that you may need to expand the contact investigation?
The patient claimed that there were no social activities such as bars, sports, churches. But there were 4 contacts that I did identify who were also bricklayers, just as he was. And at times, they will work with him on larger jobs. They are tested negative in the first round and were informed that a 3-month follow-up was needed in order to be considered evaluated. All 4 later refused follow-up testing. For some reason, they felt that they were evaluated the first round and they were okay. But I also gave them some information regarding additional testing at any one of our health centers.
Well, these are challenging cases, Tony, and I think you and your case managers did an excellent job. If there's no further questions, thank you, Tony. And we'll move on to case number 3, and Katie's going to present that case.
Case number 102348, 43-year-old female, born in Vietnam, arrived in the U.S. 2008. Special therapy negative, or quick done on 5/8/10, on no medications, no coexisting medical conditions. Risk factor, she was born in an endemic country, and TB control was notified on 4/28/10. It's a sputum smear negative case, culture positive. Collection date of the smear was 4/28/10. The culture positive collection date 4/28/10. The conversion date of the culture was 5/28/10. The case was assigned on 4/29/10, and the patient was interviewed on 4/31/10. The patient is pan-sensitive, has an abnormal non-cavitary chest X-ray. The patient initially was started on INH and rifampin only on 5/4 by a private provider who we had consulted with when we realized this on 5/8, and he agreed to co-manage the patient. We picked the patient up for DOT on 5/8/10 and began right. The patient has completed medicine, completed within 12 months, and the completion date was 11/31/10. The patient finished 6 months of DOT therapy with a compliance greater than 80%.
Thank you, Katie. Challenging when we work with our private providers. Dr. Wang, you had a few questions?
Yes, Katie, I heard aura quick, but I didn't quite hear what was the HSV status of the patient?
When the patient was initially reported to us, the private provider had not tested the patient. So we did an aura quick in the field with the first DOT visit, and the patient was negative.
Great, thank you. And then can you review again the initial medication regimen that the patient was started on?
Yeah, unfortunately on 5/4, the provider had put the patient on INH and rifampin only. And in having conversations with the patient and the provider, we were able to have one of our clinic physicians call this provider, consult with them, agree to the co-management, and to have the medication adjusted, which was done on 5/8, and that is what we take to be her start date of therapy when she was placed on RIPE.
Great, thank you. Once again, it shows how working with a private physician can be challenging, but great job on the team for getting the medication adjusted quickly and then having the appropriate completion date with the new regimen. Good job.
Yes, I agree. Thank you, Katie. Do you want to present the contact investigation for this case now?
Yes, the patient, we identified 3 contacts. None were inappropriate for evaluation. 3 were appropriate for evaluation. 3 were evaluated. And all 3 first and second tests negative.
And with your contact investigation, were there any other social settings or any other at-risk contacts that you were concerned about?
In doing this investigation, we tested the spouse and 2 friends, close friends that she identified. And since all 3 were negative and we felt they had spent the most time with the patient, the only other activity she identified was going to morning mass. She was not in the choir, and since the immediate family and friends were negative, we decided not to, these lesser areas of contact, we felt we didn't need to do an investigation there.
Very good. You're going to present case number 4.
Yes. Case number 102436, a 36-year-old female, USA born, special therapy positive, date of testing 6/1/10. Patient currently refusing antiretrovirals, has a risk factor of IV drug abuse, cocaine. TB control was notified on 6/10/10. The patient was sputum smear negative, culture positive. The collection date for the smear was 6/1/10. Culture positive, collection date 6/1/10. Date assigned 6/10/10. The conversion date was 1/5/11. The date of interview was 8/5/10. And the delay in interview was a delay between the hospital reporting the patient to us, and at which such time the patient had already left AMA, and then it took us over a month to locate the patient. The patient was initially pan-sensitive on 6/1/10, but however, on 10/1/10, the patient felt bad, went to the emergency room, got admitted. The chest X-ray was worse. The smear was now positive. The culture was again positive. We suspected MDR, and her medications were changed at that time. So on 10/1/10, she was listed as an MDR case, now resistant to INH and rifampin. Her chest X-ray was abnormal non-cavitary. The patient started treatment again. Her initial start date for RIPE was 8/5/10 when we located her. For some reason on 9/7/10, the provider seeing her took her off of rifampin secondary to a drug reaction. and did not initially allow us to do DOT, felt that the patient was dealing with enough, just finding out that they had immune system issues and was having a lot of problems, so did not agree initially to DOT. But on 10/1, with that new admission, we got a court order for DOT, and due to the previous refusal and now her suspected MDR status, and began DOT on the 10/1/10 on the MDR regimen, and that became her new therapy treatment start date. The patient has not completed therapy, will not complete in 12 months, and is currently on meds and has taken 4 months of the MDR regimen. We expect the completion of her therapy to be somewhere 18 to 24 months, or around October 2012. The patient has completed 4 months of DOT, and that's from the 10/1 date, with about a 95% compliance, and that was really initially due to the court order.
Well, this is a very complex case, Katie. In your summary, just demonstrates with the cohort review process of the resources and the time that it really takes to work with these high-risk individuals. I had one question about the delay in the interview. I see that the case was assigned and then there was a almost 2-month delay in interview. Could you explain that?
Yeah, unfortunately, like I had previously stated, the patient was admitted to the hospital, went AMA on the same day that the hospital reported her to us. So we missed that face-to-face meeting. We did go to the home that she had an apartment. We got the emergency contact numbers that the hospital had. None of those panned out. She never opened the door, even acknowledged that she was home when we were there. We sent her name out through our lost to follow-up list to all the area hospitals, the jail, and the morgue. And we're finally able to locate her on 8/5, and that was the day we did the interview and got her started again on treatment.
Thank you. Again, many resources, much time for this case. I believe Dr. Wang had some questions.
Yes, just a couple questions. One is, I know that she had refused DOT initially, and then I commend the team for getting a court order later on when it was just a little bit too late. But initially, were you able to really talk with the private care provider or work with her HIV case manager to try to get the patient DOT'd?
Initially, the patient did not accept that she was HIV positive, and we were working with the private provider. However, due to her initial negative smear and the provider feeling that they had a good relationship with the patient would comply, we actually lost in court because of the negative smear. But when we were able to show them that she was non-compliant, and by that time the provider had no objections to us doing DOT, we went back to court and picked her back up. She had, refused initially acknowledging her HIV status. The last CD4 count we had on her was January 10th, 11th, and she had a CD4 of 209. But however, since the court order, and she's met with our staff and realized that, we're only trying to help her, and we are accessing some of the incentives that come along through the HIV program, such as housing and helping with rent and food, she is now considering going on treatment and working with an HIV provider.
Okay, good. And then the other question I had was regarding the rifampin that was discontinued. There was some question whether it was an allergic reaction. Rifampin is such an important part of our initial regimen, even though the patient later became resistant. Was there any documentation of this as a true drug reaction?
No, what was listed in the medical record was really skin rash. And of course, we would have evaluated that more closely if we had been totally managing the patient. But unfortunately, working with the providers, they had taken them off the meds, and then, of course, till we found out, and then we found her back in the hospital.
Very difficult case. And then just last question, after you guys suspected multi-drug resistance, what was the regimen again that you started the patient on?
On 10/1, the regimen began amikacin intermuscular, and that was a patient choice, PZA, ofloxacin, epionamide, and Pacer. We did have to add B6, 100 milligram dose, and Synthroid because within a month she had labs that were showing some hypothyroidism.
Okay. I'm glad you guys used this. The injectable is really important when you're suspecting MDR and once the MDR was confirmed. So that was good by adding that plus additional agents at that time. Thank you.
Katie, I had a few remaining questions here on the case. You had mentioned the commissioner's order, and that is so important in this high-risk individual, and including acquired drug resistance. So is that process difficult, or do you have already established policy, procedure, protocol?
Yes, there is a protocol within the department through our legal branch of the Department of Health, and we are able to move forward once we have all the documentation together within 24 hours to get a hearing. However, we have to show that each step of the way, what we have done through documentation to help bring this patient into compliance, meeting them, possibly offering off-hour DOT, providing incentives. You have to really have clear, good documentation that we've gone above and beyond to try to help this patient, and the patient is not accepting it.
Excellent. Good work. Good policy in place. And what was her housing situation?
She was actually able to maintain an apartment, and that was the address that the hospital had given us. She does get a disability check, but we were never able to locate her there. So what we had to do is start looking in the known drug areas that we knew of, and that is eventually how, we were able to locate her and find her.
Great. And as was mentioned in your excellent presentation, and then discovering that we had acquired drug resistance, then you readjusted the treatment regimen, and the completion date was adjusted to how many months?
The completion date, she's going to be 18 to 24 months, minimum 18, and at least, somewhere between 18 and 24. So that puts her at a completion date of October of 2012.
Very good. If there are no other questions then, Katie, do you want to go on with the contact investigation for this case?
During the investigation, we identified 5 close contacts. 5 were appropriate for evaluation. 3 were evaluated, and of those 3 were negative. 2 were adults, and 1 was a 2-year-old child.
Dr. Wang, I think you had a question here on the contacts.
Yes, I noticed that the contact investigation was not started until October. Given that the patient was high risk, even though she was seronegative, was there any concerns or policy to maybe do the contact investigation initially when she was first diagnosed back in June?
Yes, we actually did attempt to do one through the initial reporting, but however, the only information that the hospital had was basically her name, her address, and like I said, going there, we were never able to get her. In our lost to follow-up list that we sent out to the other facilities, we do ask, even if the patient is not in-house, do you have any emergency contact information? But most of the numbers were non-working numbers, and it was just a person's name or a number. And it wasn't until when we located her on 8/5, she was pretty angry and hostile and not giving up much information other than these 5 people.
Thank you.
Katie, we know with a substance abusing culture, it makes it very difficult for barriers to a contact investigation. Either people aren't aware who their contacts are, or they don't want to name people. So we have to use other means or alternatives. What type of strategies do you have in trying to work with the substance abusing culture in trying to identify these contacts who are at risk?
Well, once we were able to work with her a little bit, and when she went back in the hospital on 10/1, she really was scared, and in going back several times to speak with her, bring her some small incentives while she was in the hospital, we were able to get these few names, and she did identify an area where she normally did her drugs, and it was an open air market, open drug area in one of the local parks. And we did identify 2 other contacts, but in talking to them, the field worker talked with them first. They refused. One of the case managers went out and spoke with them, still refused. And then we did try to locate once again when we found out that it was MDR, have not been able to find them again, and we actually have not given up on those 2. We're still going to try to find them. but it was mainly gaining her confidence and trying to work through that, we're not going to work with the police. We just need to get these people tested.
Very good example of the difficulty, but the strategies that you applied were excellent. Again, this substance abusing culture, high risk for HIV, do you screen your contacts?
Yes, the 2 contacts got Oraquix, the 2 adults. There was a 2-year-old, and unfortunately, the 2 adults were her drug partners that she usually used with, and the 2-year-old's mother actually refused to have the child evaluated or tested. So what we had to do was go through protective services. They brought the child in for the evaluation. The child was negative, but mom refused the window prophy even after speaking with the nurse and our physician. Protective services did mandate the evaluation, but was not willing to override the mom's refusal of medication. The mom cited the side effects of the medicine, that she didn't want to hurt her child. We, again, explained that this could be much more damaging if the child actually came down with MDR, but we were not able to persuade her. We reached out to the child's pediatrician, hoping that maybe they had a better relationship and would be able to convince her. The pediatrician was not, but it did put the pediatrician on notice when they see this child to be able to follow them a little bit more closely in addition to us. But the mandate from Protective Services is we'll be following this child for 2 years.
Very complete follow-up. Again, as we know, children are certainly at very high risk, and this is important follow-up that you have explained with this investigation. And Dr. Wang, I believe you had some questions.
Yes, thank you, Kim. And Katie, it's another very challenging case, and you guys really working with the Child Protective Services and the private physicians and really trying to educate the family and the mom on the importance of following the child and window prophylaxis, even though she's refusing. What is the plan in terms of following these MDR-TB contacts and the child?
Everyone will be followed every 3 months for 2 years, and I know you can go 3 to 6, but because of the drug history, we're afraid that if we let it go any longer than 3 months, we may not be able to locate them. So we really want to keep close tabs on them, sure that we are able to follow them closely.
Good job, and good job getting the contacts retested of those that initially refused, so good.
Well, Katie, that was excellent. Very challenging cases. We unfortunately see more challenging cases than not today, but excellent presentation, and your team did a great job. So if there's no further questions, we will move on to Christina, who is now going to give us a summary of the outcomes of our cohort review today.
This is Bill. I just want to have everyone imagine that we're going through a fast forward. You've just heard 4 cases presented, but this cohort had a total of 25 cases. So imagine that 21 more cases were presented, and now Christina's summary will be based upon the outcomes of a review of all 25 cases.
Thank you, everybody, for great presentations. I'm going to present the results of this cohort. This is the second quarter of 2010, and today's date is February 10th, 2011. All indices presented will be as of today's cohort. So our index of completion as of today is 54.5%. Our index of completion, including those who are likely to complete, is 90.9%. The national goal being 90% and our program goal being 70%. So we are exceeding both goals. Good job, everybody. Our death rate, which includes those cases that were reported at death and those cases that died during treatment, was 8%. Our default rate, which includes those patients that were lost during their course of treatment and those who refused to initiate treatment, was 4.2%. Our total cohort failure rate, which doesn't mean that we failed in doing our job. What it does mean is that these include the cases that were lost, the cases that refused treatment, and those that were cohort failures or are not going to be able to complete their therapy within 365 days of treatment initiation. That is 8.3%. The percentage of eligible patients ever on DOT was 78.3%, and the mean months of DOT per patient was 6 months. We counted 12 student smear positive cases, and for the time to interview, our mean number of days was 1 day per case, and 92% of our cases were interviewed within 3 days, and we have a goal of 90%. So we've exceeded that goal. Good job. This chart shows the student-fair positive interview trend, and as you can see, over the last several cohorts, we have been steadily improving our rate. So well done. Our time to interview, other interviews, this includes cases that were sputum-sphere negative, culture positive, extrapulmonary, and clinical cases. We had a mean of 11 days per case for getting cases interviewed, but we did have a percentage of 85%, which means we probably have a couple of outliers who skewed our numbers. Addressing the contacts, we had 22 pulmonary cases, which are cases that are eligible for contact investigations. When we interviewed them, we got 175 cases for a contact index of 8 contacts per case. Of those 175 cases, 174, or 99.4%, were eligible for evaluation, and of those, we evaluated 140, or 80.5%. The national goal is 90% of contacts with sputum-smear positive cases will be identified and evaluated. Of those contacts that were evaluated, we tested 117 for 67.2%. 27 of those were infected for an infection rate of 23.1%. We had one case that had disease, no suspects. For those cases that were appropriate for treatment of LTBI, we had 26 cases, and all 26 were eligible and had started treatment. We had 4 that completed. We have 18 that are still on treatment at this time. We had 1 that refused to continue treatment, no adverse reactions, 2 that were lost to follow-up, and 1 that moved out of jurisdiction. The last possible cohort that had a chance to complete a full course of therapy would be the 4th quarter of 2009. Our best possible completion rate for that cohort was 100%, and our finalized result was 81.8%. There were a couple of cases that were not able to complete due to drug challenges. This is our trend over the last few months of cases who were likely to complete versus cases that actually completed therapy. As you can see, we are having some gaps between those cases we think will actually complete therapy within 1 year and those who actually do complete. And so we're working to close those gaps, and we're getting better. The goal was 90%, so we still have a little bit of work to do. For LTBI completion, the blue bar is our average over the last several cohorts of every contact that was evaluated, and the white bar is the most recent cohort that would have had a chance to complete a course of therapy for latent TB infection. As you can see, we are doing pretty well. We average at evaluating about 80% of our contacts. We have an average infection rate of 35.6%, which is a little bit above the national average. But we do well at starting all of our contacts on therapy and getting them to complete. The last cohort we did was 1st quarter 2010. In that cohort, we counted 37 cases. There were 10 case issues identified, and 9 of those issues were resolved or addressed. An example of those issues included following the CDC guidelines for HIV testing for all patients between the ages of 15 and 70, following the new CDC guidelines to treat all HIV-infected patients who have been recently exposed to TB regardless of previous treatment, noting that INH resistance is something that we are watching closely, investigating systemic ways to alert hospitals and other jurisdictions about infectious patients who may be lost, and then some database issues including closing cases in the TB registry, updating contact information, and expanding contact investigations when necessary. At this time, if there are any questions, I'm open to hearing them.
Thank you, Christina. It's interesting that our issues that we identify, are we going to really see with reduced resources that we're all experiencing if we're going to be able to work on these issues, or will they be continuing as ongoing with short staff and time to address these issues? And that is really one of the benefits of Cohort, is to document what has occurred over time or what we're not able to do. So thank you. Those were excellent. Our cohort today has concluded, and we will come back together in May at the same time for our next cohort review. Thank you to all the presenters today.
Okay, this is Bill again. That ends our simulated cohort review, and now we'll talk a bit about the benefits and the challenges of cohort review, and we'll take your questions. I'd like to invite each of the presenters to actually tell us, what does cohort review mean in your program, and what sort of benefits have you seen it bring?
So one of the challenges I see often, and some of these cases, this is Kim again, when the case is being presented by the individual, it may not be the case that they've cared for, and it may be as often as happening today with a private provider. So the cohort review really provides that opportunity to identify interventions of really working with the private providers and the challenges of being successful doing that.
This is Sue Wong. I think for us, it's really brought our program together in the sense that we're able to really see the data. We've always been doing case management and contact investigation, but with the cohort review process, we've been able to really present the data in a formatted fashion and see the results of the data presented and compare our results to that of the national average and to our previous average. So I think, and then all of our TB team is allowed to come to this, so I think they can actually see what we're doing. So I think in that sense, it's really brought the program a lot closer together, and people know what the beginning and the end points are. And some of the challenges were just getting the program started, but I think now that we've gotten it started, we've definitely seen the benefits of the program, and we'll continue with it.
And this is Katie. For us, it's meant increased accountability. It allows you to take another in-depth second look at your case. The data drives the changes that we make, and in many cases, it becomes a good teaching moment.
This is Philadelphia, and I just echo all the sentiments of the other presenters that we kind of use the phrase around here, what gets measured gets done, and so it helps us to know what it is that we are doing really well in and what we need to maybe focus on in terms of maybe adjusting policy or creating policies or creating teachable moments for training for our staff. And for me, from an epidemiologist standpoint, it's a little bit self-serving because it helps me to kind of get reports and data together a lot faster because the data is already clean, it's already ready to go, and it's already in a pretty usable format.
Tony, I'd like to ask you, as someone who's out there investigating outbreaks of TB, working with patients in that firsthand, how do you see cohort review?
Well, one of the challenges was always, we started off with the old case reviews, which would take 2 and 3 days sometimes just to oversee maybe 10 cases. One thing that's worked for me is that where I've implemented that at the time that the case gets assigned, we actually start the cohort process. We enter all the data information, anything that we can obtain during the initial report, we obtain that information and put it on the sheet. So that kind of helps me do what I need to do as a supervisor. So far, we haven't had any complaints. No one wants to go back to the old case reviews. The cohort, we can actually go through maybe 20 cases within maybe an hour. So that kind of frees up time for other workers to do what they need to do in the field. So it's a great benefit for me as a supervisor, and I'm sure it's a great benefit to my staff, the outreach workers.
Yeah, actually, I was tracking the amount of time it took us to review the 4 cases today, and case number 1 took 6 minutes, case number 2, 7 minutes, case number 3, 4 minutes, and then the really complex case, we took 18 minutes to go into that very complex MDR case. And so I see that it can be done quickly, but you can really manage it so that where you've got the most to learn, the most work to do, that one you can put more time into. I think that was a good use of time. I think many programs can do this sort of like averaging maybe about 5 or 6 minutes per case. I'd like to move on to the issue of challenges of doing this. Some people have the impression that, oh my God, it's overwhelming, it's really hard to do. Others see it's not too much harder than what you did today. It's just something that you buckle down and do. I'd like to ask each of the presenters, tell us what sort of challenges do you have, and do you think that others would have if they're getting started?
Well, this is Kim again, and the way that we started and we continue today in Washington State is that we have the large city of Seattle, which is King County, and they have half of our cases in a year at any one year, and then we have the rest of the state. A lot of rural areas, maybe some of those counties don't see a case in 5 or 10 years. But we were able to combine with all of our staff going to Seattle, spending half a day with Seattle, and then the remainder of the day with the counties calling in on a conference call because they would not be able to travel, even quarterly. That maybe sound like a challenge, but, since 2003 there hasn't been one area that has not wanted to participate. And I think of a challenge is that right now we have staff turning over and people coming into programs that don't have the necessary knowledge really or the access to have training and education. So this provides that opportunity.
And this is Katie from D.C. I really think a lot of the challenges are more of a perceived challenge than they really are. We were able to put the process in place fairly quickly because we borrowed everything from all the other places that were doing it and then just adapted it to meet our needs. Probably the most to overcome is the initial reluctance, but once you actually get past that cohort to a person here, I don't know of anybody that doesn't believe in Cohort and has been able to see immediately what it does for us.
And this is Sue Wong from Franklin County, Columbus, Ohio. So for us, I just wanted to mention about what Bill had said about the time. We had 66 cases of TB in our county last year, so each cohort session is about 15. And because I'm the medical director, I review the cases prior, and we have case management sessions, and we also have contact investigation sessions. So the cohort actually goes pretty quick. It's maybe an hour to 2 hours at the most, and our epidemiologist has all the data ahead of time so we can crunch out the numbers. So it can go quicker if you're more familiar with the case. For the presentation today, it was kind of like an outside reviewer who didn't really know the case, so a lot of questions were asked in more detail. In terms of our challenges, and I think I agree with Katie, it was just once we got buy-in and we got it started, it went very well, and we did borrow the format and stuff from other programs that are established, and then once we got it going, we kind of revised it according to our own needs. So I think once you do it, I think you'll see the benefit.
This is Katina from Philadelphia, and I agree with all the presenters again. I think a lot of the challenges were perceived challenges as well. It's a matter of getting buy-in. When I actually started working with the TB control program, they were already doing Cohort, and one of my first jobs was to get Cohort ready, and I was able to kind of slide right in as a brand new staff member and get it done. So it's very easy to really adapt yourself to it, and as much as there are things that people find that could be problematic with it in their minds, those are the things that actually make it a really good process because it allows for discussion, it allows for, teaching, and it allows for people to walk away, including our division director who doesn't know on the day-to-day what we actually do, but she can come to the cohort meeting, listen to our presentations, and she walks out knowing exactly what the TB program has been doing from start to finish for each and every case that we take care of.
Well, thanks very much. I guess, what I'm seeing is that, in fact, each cohort review process in each one of your programs sort of has its own personality. Sometimes it may be a real free-flowing discussion in which you've got social workers or pediatricians or community doctors or outreach workers involved. In other cases, it may be something a little bit more formal, reviewing a lot of work that's already been done that you're already familiar with, and it can be used to still highlight important teaching points. In some programs, it's done over the phone or over live web communication, and it's got sort of a distance education approach. In other places, it's a group meeting with a breakfast or a lunch or something served there that makes it a real kind of a gathering way. Either way you do it, I think it really can be effective. So I really want to thank all of you for sharing what you've been explaining about how you're doing and for acting out a cohort review. That went really well. By now, I'm sure that the listening public may have questions. I do have one question that came in, and so I'll go ahead and throw this out. I know earlier I said that if any of your programs has a different policy than what you see shown by the people doing the review today on the webinar, that's because your policies are different. It's not because one way is right or one way is wrong. But a question came in saying, why is it that you are measuring the months of DOT in months rather than actually measuring the number of doses that were taken? So I'm curious, any of the presenters, can you tell us why does your program do it? Because it's more convenient or it's hard to track all the information dosage-wise? Why is that?
This is Sue Wong. We actually count the number of doses. So for Gail who asked the question, we do count the DOT doses. The month just kind of gives us a ballpark idea.
This is Kim on that question. What's happening in Washington State, and I've been getting input from other states, that as the resources are dwindling, people are really, unfortunately, approaching that let's cut DOT of all things. But it is happening in real time. And I think it's just very important to speak to the amount of time also that the individual's on DOT. If we're going to have these abrupt changes, hopefully we'll be able to maintain the first part of a therapy. But it gives the picture of the whole case management.
This is Christina from Philadelphia. I think we do months for the same reason. It just makes it a little bit easier for people to understand, especially if we do have outside people who come in. It just keeps things going a little bit smoother, and also we know that the numbers change based on the actual clinical characteristic case, so we don't want people getting confused.
And it's Katie from DC. We use dose count to get towards completion, but in presentation, we just do it by month.
Okay. Another written question came in saying that on the cohort forms, looking on the notes and definitions on the back side of it there, they're saying, why are you asking if adherence has been below 80%? Is this used to determine if treatment has been completed? And if so, do you consider completion of 80% of recommended doses as adequate treatment completion? I know it's important to make sure that you've got your definitions understandable for everyone in your program. So this, again, is a question looking at someone else's policies rather than the process. Does anyone want to comment on how their program looks at that? We just did hear that in D.C. and Ohio, they're actually counting doses. So I would assume then, on their forms, they could specify the number of doses. But Christina, I guess, you guys and some other programs are going mostly by months of completion.
We do count the doses, and then we convert those into months. It just makes our lives a little bit easier.
Okay. So I think, Jill, you asked that question. You can see that most of these programs, I guess, just to throw up a rudimentary number are throwing up whole months in which adherence was 80% or better. But they are counting doses on the side, they admit. Are there any questions?
Hello? I have a question about definitions. I have a question about the definition of compliance rate. How do you define compliance to get a rate? And then there's number of eligibles for DOT. What is appropriate for evaluation and what is appropriate for LTBI?
I'll jump in and give you a really quick definition. For your program, those definitions should be whatever your program has set them to be. You don't have to follow the definitions used by any of the programs presenting here. But now I'd like to invite the programs who just presented to go ahead and give their rationale for these.
Hi, this is Katie. To figure out compliance rate, you take the number of DOT days that you would be able to do in a month, and you divide that into the actual number of days that the patient did DOT, and that should give you your compliance rate. So for January, to count the number of available DOT days, we would not have taken the holiday. We would have taken that out. So again, you count your number of actual DOTs and then divide into that the number of days you could have actually DOT'd the patient. We actually have that tabulation on the bottom of our DOT calendar so that every month it includes the dose and the compliance rate for the physician.
Thank you.
And then did you have a question about evaluated, what that meant for contacts?
Yeah, there were things on the spreadsheet like number of contacts that were appropriate for evaluation, number of contacts appropriate for LTBI treatment.
This is Bill. I'll break in here. Some programs I work with consider that all contacts that were named should be evaluated unless they have died before it was possible to evaluate them. So that is the only excuse for not being able to be evaluated. Your program could do it the way you want it because the situation in New York City or Philadelphia or Ohio may be different where their program is. And you should follow the policies and protocols of your state, your city, your county's health.
Well, I agree. The definitions that were developed here in Washington State were done by a whole panel that included county case managers, physicians, and, everyone that's involved with cohort. That's one of the processes of setting up your cohort, for sure.
We have another question. How does the epidemiologist practice filling in the spreadsheet in real time? Because it seems like a real challenge to do this while the information is coming in rapidly. Christina, can you take that one?
Yes, I can. The way I practice really is partially I try to make sure that I get as much of the data into the spreadsheet before cohort even happens. So I'm constantly talking with staff and we're having meetings. We do practice sessions where the staff will come in and start going through their case presentations and anything that I can definitely say, okay, this is a definite data point. Let me get this in the spreadsheet. It goes in and it stays, and then during cohort I actually update information. And as far as practicing, you just have to get very familiar with it, learning how to quickly navigate across the spreadsheet because it is a large spreadsheet. It's just a matter of practicing, and it took me a few tries to really get it down. But also during cohort, I really just try to focus on the voice that I'm hearing presenting and the words that are coming out of their mouths. I'm listening for key words to say, okay, this is where that data point goes. So I really tend to block out everything until it's time for me to start talking again.
Okay, well, It actually is all the time that we have allotted for the seminar today. I'm including right here the contact information for all of the presenters who have been part of this series of webinars. And at this time, I want to extend our sincere thanks to all the faculty for sharing their knowledge and experience with us. For me, it's been a real pleasure working with this series, and I hope you found it useful. Please count on us to keep helping you to get cohort reviews going. Lastly, I want to thank all of you for your participation, participants and presenters alike. This concludes the conference.